If some more people float in, that's good. So for those who don't know, my name is Josie Mirabelli, and I decided to do my presentation on micronutrients and pregnancy. In regards to questions, if it's okay, if everyone could just leave them to the end and do the little raise the hand option or just write in the chat box, that would be great. So I chose this topic because it feels like there's constant, just evolving changes in what you can do during pregnancy and how to have the best pregnancy outcome. For example, I was talking to my grandma and she said that people were smoking in the hospital when she gave birth. My mom said that it was okay to have caffeine and alcohol. And I was talking to two of my preceptors who are pregnant, and they were telling me about the different recommendations they have and have been given by their OBGYNs. So I decided to do this to figure out what new ideas and findings are there from a nutrition standpoint in how to have the best pregnancy outcome. So the things that we're going to kind of go over today, so a basic overview of micronutrients and their importance, what a healthy pregnancy diet includes, and why it's important to be aware of. 3 important micronutrients to make sure that you're getting enough of during pregnancy, as well as their functions, some good sources, and how much you need. And then we'll look at 3 research review articles, one on each of the 3 key micronutrients in pregnancy. So a basic overview of micronutrients. So these include your vitamins and minerals, and they're really important for overall healthy development and growth, preventing diseases, and overall well-being. They're primarily obtained from the diet and supplementation, with the exception to vitamin D, which can also be obtained from the sun. Some deficiencies in specific micronutrients can lead to specific devastating consequences, and pregnant women and babies are especially vulnerable to these consequences. So what a healthy pregnancy diet looks like. So first and foremost, it's really important in just promoting the baby's growth and development. The basic principles kind of align with what a healthy diet looks like for most people. So having plenty of fruits, vegetables, whole grains, lean protein, and healthy fats. A daily prenatal vitamin is recommended starting 3 months before conception. And while there's no magic formula for a healthy pregnancy diet, there are a few nutrients that deserve special attention, and those 3 key nutrients are calcium, folate, and iron. So calcium is extremely important in helping building strong bones and teeth. It can help in multiple systems functioning, and that includes circulatory, muscular, and the nervous system. It can decrease the risk of preeclampsia, having preterm birth, and low birth weight. Some good sources, the best source is dairy. Some other good sources are broccoli, kale, fortified fruit juices, and cereals. And it's recommended to get at least 1,000 milligrams a day during pregnancy. Folate. So this is essential in the earliest days of fetal growth for healthy development of the brain and spine. Ensuring sufficient levels before conception can reduce neural tube defects. These include spina bifida and anencephaly. Folic acid is the synthetic form that you'll find in your supplements and fortified foods. A supplement is recommended to women between 15 to 49 years old and all women who might become pregnant. It can help in decreasing the risk of premature birth. And some good sources include fortified cereals, leafy green vegetables, citrus fruits, dried beans, and peas. And it's recommended to get between 400 to 1,000 micrograms a day. And finally, iron. So your body uses iron to make hemoglobin. This is a protein in your red blood cells that helps in carrying oxygen to your tissues. It's used to increase the blood production to supply oxygen to your baby. Your body needs this iron to increase the blood production. It's critical for motor and cognitive development, and you actually need about double the amount during pregnancy. it can help decrease the risk of iron deficiency anemia as well. Children and pregnant women in general are especially vulnerable to the consequences of iron deficiency. And you can develop iron deficiency anemia if you don't have enough iron stores or if you don't get enough iron during pregnancy. And so one of the examples of side effects you can get from this is feeling fatigued. And severe iron deficiency anemia during pregnancy also increases your risk for having premature birth, having a low birth weight baby, and postpartum depression. Prenatal vitamins typically contain iron, so if you're taking one of those each day, then you should be good. It's always important to look at that label. Some good sources include lean meats, poultry, fish, iron-fortified breakfast cereals, beans, and vegetables. And it's recommended to get 27 milligrams a day during pregnancy. And as a side note, iron from animal products is the most easily absorbed, and vitamin C can help with that absorption as well. So moving into what the research is saying now. So the first article was over calcium, and it's titled Calcium, a Nutrient in Pregnancy. It was published in 2017, and the objective was to determine the effects of calcium intake on maternal and infant health. So as an overview of the article, it was a research review article, so it looked at multiple different studies and kind of put their outcomes together. The dependent variables were preeclampsia, preterm birth, birth weight, and infant bone density. Preeclampsia is classified, it's a pregnancy complication where you have high blood pressure and you can also have protein in the urine, swelling in the legs, and water retention. A preterm birth is classified as a birth that occurs before the 37th week of pregnancy. A low birth weight is when the birth weight is lower than 5 pounds, 8 ounces. And the infant bone density looked at the total body calcium content. The methods, so each of them supplemented between 0.5 to 2 grams of calcium a day during pregnancy and compared that to a placebo group that didn't supplement any calcium. The 3 studies included cohort studies, a Cochrane review, and randomized controlled trials. So cohort studies, they investigate the causes of a disease, and then they look at the links between the risk factors and the health outcomes that they find. So they look at groups of people or a cohort. Cochrane reviews are known as the highest standard in evidence-based healthcare. They're a systematic review, which basically means it's a collection of multiple sources with secondary data and repeatable studies. And then randomized controlled trials, so these are basically chance alone. So they're allocated at random to receive one of a set of clinical interventions. In this case, having or not having a calcium supplement. So the first study was a cohort study, and it looked at preeclampsia and preterm birth. So it included 524 healthy women who were pregnant for the first time. It occurred at a tertiary care hospital in North India, and they provided daily supplementation of 2 grams of calcium a day between 12 and 15 weeks. And the findings was that there was a 66.7% risk reduction of having preeclampsia, and the risk for preterm delivery was decreased by 12.7% versus a 7% decrease in risk of the preterm delivery in the placebo group. The next study was a Cochrane review, and this looked at preeclampsia. So this was a huge review. It included 13 trials, which totaled in 15,730 pregnant women. And the findings were that the risk of preeclampsia was significantly reduced in those receiving a calcium supplementation in pregnancy. So this one was a randomized controlled trial, and it looked at birth weight. So there were 510 healthy first-time pregnant women, Argentinian women before 20 weeks gestation. It included a placebo group of 230 participants and a treatment group with 1.5 grams of calcium a day, and this had 231 participants. And the general findings was there was a 15% decrease in low birth weight. This randomized trial looked at infant bone density. So the participants, it included 256 women before 22 weeks gestation. And the 2 groups were either received 2 grams of calcium a day before or until they delivered, and a placebo group. And they used DEXA measurements, which measured the entire body and the lumbar spine of the neonates within their first week of life. And the general findings was that the total body mineral content was much higher in the treatment group, specifically 64.1 grams in the treatment group versus 55.7 in the placebo group. And it was generally found that supplementing an average of 1.3 grams a day from mid-pregnancy to term can enhance the fetal bone mineralization in women with low calcium intake. So these were 2 more general trials, so I decided to put them together. 2 randomized control trials that looked at preterm birth and 1 at preeclampsia. So for preterm birth, it was a range of 11 trials, and the findings were that there was a 24% decrease in the preterm births. For preeclampsia, it looked at 15 randomized control trials, and the general findings was that there was a 52% decreased risk for having that high blood pressure and a significantly reduced risk of maternal mortality and severe morbidity. So in conclusion, there are significant physiological changes that happen in a woman's body to maintain the calcium homeostasis during pregnancy. And the mineral demands of the fetus are hugely met by increasing calcium absorption. And in general, daily calcium intake of pregnant women has reported to be low. So in conclusion with this study, calcium supplementation for pregnant women with deficient intake offers modest benefits in preventing preeclampsia and preterm births and improving maternal and infant bone health. So the second article looked at folic acid, and I decided to look at this one because I've always heard folic acid is really important to be taking 3 months before conception through the first trimester. I was wondering if there were any benefits continuing that supplementation into the second and third trimesters. So, and this article kind of looked at that. So it was titled "The Effect of Continued Folic Acid Supplementation Beyond the First Trimester of Pregnancy on the Cognitive Performance in the Child." And this was a follow-up study from a previous randomized control trial. This was published in 2019. And the objective was to determine the effect of folic acid supplementation during trimesters 2 and 3 of pregnancy on the cognitive performance in the child. So the study population. So this was a follow-up investigation on children whose mothers previously were in a trial titled the Folic Acid Supplementation during the second and third trimester trial that took place in 2006 and 2007. So the criteria for the mothers, so they had to be healthy, pregnant, between 18 and 35 years old, and taking that recommended 400 micrograms of folic acid a day. They were recruited from antenatal clinics at the 14th week gestation, and they were randomly assigned. So there were 59 in the treatment group that received 400 micrograms of folic acid a day during that second and third trimester, and 60 in the placebo group, which stopped taking folic acid after the first trimester. So the offspring trial measurements included cognitive tests for 2 different age groups, anthropometric measures, which was used standardized equipment, laboratory assessments, and statistical analyses. So for cognitive tests, the 2 age groups were 7 years and 3 years. So the 7-year-old group was the main assessment, and this was measured by a trained researcher using what was called the Wechsler Preschool and Primary Scale of Intelligence test. And this was a validated clinical instrument that provided composite scores that represented intellectual function in certain areas, such as processing speed, and the overall score for a full-scale IQ. It took 40 to 50 minutes, and it was completed by the same researcher in 1 session. And the room was set to provide an appropriate environment for assessing the child, which included being well lit, ventilated, free from distractions, and the mother was outside of the child's view. The 3-year-olds, that was a pilot investigation. and that was prior to the main assessment at 7. And this used what was called the Bailey Scale of Infant and Toddler Development Test. And this is the most frequently used developmental test for infant and young children between 1 to 42 months. And this assessed cognitive performance, communication, and motor skills. So for anthropometric measurements, they looked at the height, waist, head circumference, and body fat. And for the laboratory assessments, they looked at the non-fasting blood samples from the mother at 14th and 36th gestational weeks, as well as the umbilical cord blood at delivery. So for statistical analyses, at 3 years, there were 39 children in both groups. And at 7 years, there were 43 children in each group that were used to find the significant difference in the cognitive performance between the children of mothers randomized to each treatment. And these group differences were analyzed using t-tests. So the results. So 70 of the 119 participants completed the trial at 7 years. 39 completed at 3 years. 34 of these children were from the 7-year group, and there were an additional 5 that were not available for the 7-year follow-up. And there weren't any significant differences in general for maternal and child characteristics between the groups. So for folate biomarkers, during the pre-intervention, neither serum nor RBC folate showed huge differences between the treatment groups, but both were much higher in the folic acid receiving groups. And there were significant higher folate concentrations in the treatment group and cord blood delivery as well. So for cognition, the 7-year-olds were much higher in word reasoning compared to the placebo group, specifically 13.3 versus 11.9. And they found that the folate status at the 36 weeks, when taken at 36 weeks, was a huge predictor for the verbal IQ. At 3 years, the treatment group was much higher in the cognitive domain and compared to the placebo group. And in both groups, the treatment groups had greater proportions scoring above the median value, which was 10 for 3-year-olds, and then at 7 years, 24.5 for girls and 21.5 for boys. So in conclusion, supplementing with folic acid is really important in that first trimester and 3 months before conception, with helping and preventing the neural tube defects. However, continuing that supplementation during the 2nd and 3rd trimesters can influence the cognitive performance of a child up to 7 years old. And finally, the 3rd article looked at iron. So this looked at the title was The Contribution of Iron Deficiency to the Risk of Peripartum Transfusion, and it was a retrospective case control study. It was published in 2020, and the objective was to identify the prevalence of iron deficiency and anemia in pregnant women that received peripartum transfusions relative to age-matched non-transfused controls. So this was a retrospective case control study, which is basically an observational study, and it enrolls patients that already have a condition. So in this case, they're already pregnant, and it compares them to a group with a different outcome, in this case, the transfusions. It took place in Toronto, Canada, at Sunnybrook Health Sciences Center. And the cases were obstetrical patients that received peripartum transfusion, which, as a side note, peripartum refers to the period following childbirth. And the controls were patients delivering at the institution that didn't receive transfusion at the time of delivery. And this took place between January 2014 and July 2018. Some criteria that would mean that mothers would be excluded from this trial. So if they had a clear alternative explanation for having anemia, so such as chronic kidney disease or malignancy, pre-existing transfusion dependence, if they had different hemoglobin targets for transfusion, so for example, they would have different targets in a patient with sickle cell disease, which is a group of red blood cell disorders that affects hemoglobin. and if they had the majority of their prenatal care outside of that Sunnybrook institution. So they collected a lot of data. For demographic and laboratory data, they obtained it from the patient's charts. And some of the variables were age, if they've had multiple pregnancies, they have a history of chronic malabsorption, their prenatal vitamin and iron supplement consumption during pregnancy, and so on. For a transfusion history, they obtained this from their blood bank information system. Their past medical history and dietary restrictions, they obtained this from the prenatal record. The median household income, delivery and perinatal outcomes, and components of complete blood counts and iron studies in years before pregnancy, during pregnancy, and up to 6 months postpartum. So their secondary objective was to determine the rate of below optimal care in pregnancy. This can include identified but uncorrected iron deficiency or iron deficiency anemia. So this would mean that they have like a clear deficiency without actually replacing the iron. If they had unaddressed mild or moderate anemia, or if they had a hemoglobin less than 90 grams per liter postpartum with uncorrected iron deficiency. So the descriptive statistics, so they use their statistical analysis software. So the predefined risk factors were selected based on the sufficient data. The dependent variables were used to identify statistically significant predictive factors associated with peripartum transfusion, and this was obtained from a univariate logistic regression. The multivariate logistic regression was a model that was used to quantify predictive factors associated with transfusion at delivery, and maternal and fetal outcomes were excluded to focus on the pre-existing risk factors for transfusion. And then they used an odds ratio and 95% confidence interval, and this was calculated for each of the different risk factors. So for demographics, the results, 169 of the 18,294 women received transfusions. There were 24 of these cases that didn't meet the inclusion criteria, which left 145 remaining cases matched to controls, which resulted in an overall cohort size of 290 patients. The mean age was 33.1, and this was for all deliveries at the center during the time period. So the transfusion metrics. So there was a total of 359 units of red blood cells transfused. 64 of the cases received 1 unit, 48 received 2, 33 received 3 or more, and then 4 were transfused antepartum, which means not long before childbirth, and 141 were at delivery or postpartum. So the primary outcome, so iron deficiency or anemia was found in 103 cases and 74 controls, and the odds of moderate postpartum anemia with uncorrected iron deficiency in pregnancy, moderate anemia, and mild anemia was much higher in the transfused women relative to the controls. So for the iron status results, and generally you can see here that the cases or the women that received transfusions had significantly higher amount of people that had the differing iron statuses that you can see on the left. So iron deficiency prior to pregnancy, 27 versus 9 of the controls. Iron deficiency, 72 versus 62. Iron deficiency anemia, 32 versus 11. Oral iron replacement, 51 versus 37. And then IV iron therapy, which a huge difference, 24 versus 3. So for the univariate analysis, the socioethnic factors that were found, so Caucasian ethnicity, having social work involvement during pregnancy, and residing in a low-income neighborhood had significant associations with the odds of receiving a transfusion. Women with anemia of any etiology in pregnancy had 4 times higher odds of receiving a transfusion. Transfused women had higher rates of iron deficiency anemia in pregnancy. And then vaginal deliveries were associated with a lower odds of transfusion versus an unplanned cesarean section had higher odds. So for the multivariate analysis, the factors that were associated with higher odds of peripartum transfusion included that social work involvement, IV iron supplementation, and an unplanned C-section. So for maternal-fetal outcomes, the transfused women had more primary postpartum hemorrhage and bacterial infections such as endometriosis. And babies with transfused mothers had higher rates of fetal demise, prematurity, low birth weight, and NICU admission. So in conclusion, there are a lot of social and financial barriers that could be impairing access to having that iron treatment, which includes women that are being followed by a social worker. They seem to be particularly vulnerable. So it's really important to screen all pregnant women with a first trimester ferritin for early recognition of iron deficiency. That's how you're going to have the best way to treat it. So in conclusion from this article, iron deficiency in pregnancy is common, it's underrecognized, and it's undertreated. There are implications for mothers and babies, and it predisposes women to blood transfusions, which may have severe consequences for future pregnancies. So a basic summary of my research findings. So most women are not having enough calcium in their diet. So supplementing that calcium for pregnant women with deficient intake offers some good benefits in preventing that high blood pressure, preterm births, and improving their maternal and infant bone health. And folic acid supplementation is really important 3 months before conception and in the first trimester for preventing the neural tube defects. However, in the second and third trimesters, it can also influence the cognitive performance of the child up to 7 years old. And iron deficiency, pregnant women and babies are especially vulnerable to the consequences of iron deficiency. And it predisposes women to blood transfusions, which could have severe consequences for future pregnancy, which is why it's really important to be screened early on to detect this and have the best outcome. So implications for your practice moving forward. So again, most women aren't having enough dietary intake of calcium. So that supplementation really should be recommended for women with low dietary intake. And for folic acid supplementation, it should be considered past the first trimester in hopes of aiding in cognitive performance of the child. And all pregnant women should be screened for iron deficiency early on for the best outcome. Here are my references. I know I went right up to the last minute, but if anyone has any questions, please let me know. If not, I'll let Whitney take it away.
All right, awesome job, Josie. I'm going to put the evaluation link in the chat just in case if anyone missed it the first time. And just as Josie said, please feel free to leave any questions in the chat, raise your hand, come off of mute, whatever you prefer. And just to remind everyone, the next session does start at 11:35, which is our closing session with Elena on effects of skipping breakfast. Thank you.
All right, so if no one has questions, please feel free to move on to the next presentation. Thank you so much, everyone, for joining and learning and hearing about the latest research on micronutrients in pregnancy.